A very good day to everyone. I'm Jeffrey Lim Zekang, a urologist from University Malaya Medical Center, and I would like to talk about the treatment of residual mass post-chemotherapy in testicular cancer. Which path should you use? We will talk about it. Post-treatment reassessment, you reassess the patient with a radiological imaging as well as tumor markers. The reason for imaging repeat is to assess the response after induction chemotherapy. If the patient has radicular progression despite marked decline, you should still continue and complete the induction therapy if you decide to repeat the imaging halfway. Tumor markers, alpha-fetoprotein, beta-HCG, and LDH. If the marker decline, or even if the disease is stable or regressing, you should still continue the planned chemotherapy. Complete it. No shortcut, even if it's getting bigger or smaller. Tumor markers higher or decline, you should still complete the planned chemotherapy. No question about that. Tumor marker kinetics, you can see there's a type where there is declining tumor markers, there's plateauing, there's upward curve. For those which are declining, it's good, and normally in poor prognosis non-seminomatous germ cell tumor, there is a slow marker decline. Just need to be a bit more patient, and in some case you might want to consider dose intensification. The plateauing is coming down, but it plateau, still detectable. However, it's important to know which tumor markers is the one that is plateauing. If it's a HCG, it's low level, you can still observe it, it might normalize. But however, if the alpha-fetoprotein that is persistently plateauing, you might want to consider early surgical resection. Outward curve, if the tumor markers after you complete the treatment has upward curve, you might want to think of a second line or salvage chemotherapy. Management of the residual mass is fundamentally dictated by primary histology. So this is where the histologically divergence. If it's seminoma, there's a paradigm of active surveillance and advanced imaging. Non-seminoma is a paradigm of aggressive surgical intervention. This is the important slides to memorize. So why we talk about seminoma and imaging? So what is the imaging threshold? We take 3 cm. The principle of it is the seminoma management relies on surveillance with imaging tumor markers. If the mass is less than 3 cm and the tumor marker has normalized, you continue surveillance. If the mass is more than 3 cm, the tumor marker has normalized, it triggers the recommendation for FDG PET scan. FDG PET scan is an important investigation and imaging tool for patients with a residual seminoma mass more than 3 cm. You should not proceed directly for surgery. Always PET-CT first for residual mass more than 3 cm for patients with seminoma residual mass. When should you perform the PET-CT? The optimal window is 6 to 8 weeks after completion of chemotherapy. You should not perform anything earlier than this because there's always a high risk of false positive because of the inflammation after the chemotherapy. So as what he has mentioned, the rule 6 to 8 weeks post chemotherapy to ensure diagnostic accuracy. PET-CT predictive paradox. If the PET-CT is negative, it's good because if it's negative, it has a high negative predictive value and is more than 90%. So if PET is negative, surveillance is safe. But even if it's positive, it has a low positive predictive value, 23 to 69%. So what it means is that even if the PET-CT is positive, it should not dictate treatment or surgery for the patient. So you see, even if the PET-CT is positive, RP-LND should not be based on the findings alone. So it's based on what? We have to get other parameters to decide what to do next for the patient. So this is the action protocol. And now we are talking about the patient is negative for tumor markers. The tumor markers has normalized. If persistent PET positivity without growth, you can always repeat a PET-CT in 6 weeks' time. If patient have progressively enlarging FDG avid mass, it might suggest a viable disease. You get a histological confirmation before salvage chemotherapy. So you can put a needle in, get a histology, confirm viable disease, then you proceed for salvage chemotherapy. These are for patients with negative tumor markers. Tumor markers has normalized. However, the mass is still there and more than 3 centimeters. Next, we talk about non-seminomatous germ cell tumor. So basically, in a patient who has a residual mass post-chemotherapy for non-seminoma, 40% of it can be benign, 40% of it can still be malignant. And out of the 40%, 33% is teratoma, and as we have known, teratoma is chemoresistant and required resection. And 7% of it is a viable cancer, or what we call active disease. Because roughly 40%, as what I mentioned just now, contain teratoma or viable cancer, FDG PET has no role in post-chemotherapy non-seminomatous germ cell tumor assessment. Instead, the scalpel replace the scanner, send the patient straight for surgery, RP-LND. So non-seminoma, no PET-CT. Non-seminoma, no PET-CT. If the patient has residual mass more than 1 centimeter, the patient should go for surgery. RP-LND, the surgery that we talk about, retroperitoneal lymph node dissection, the threshold is 1 centimeter. Mandatory surgical resection for residual masses more than 1 cm and is best performed within 6 to 8 weeks after chemotherapy. Yeah. If the patient has a complete radiological remission, it's good. However, if the patient has residual mass less than 1 cm for non-seminoma, you can actually offer the patient surveillance versus surgery. And this is individualized treatment. And importantly, go through a multidisciplinary team meeting. The reason we can offer surveillance is because the recurrent risk for less than 1 centimeter residual mass is actually quite low, 6 to 9%. Yeah, so surveillance is still not a bad idea for non-seminomatous germ cell tumor, but definitely involved for MTT. Surgical methods and objective. Our objective for RP-LND is for complete oncological resection while preserving the ejaculation function. Gold standard, always open retroperitoneal dissection, but at this era where MIS or minimally invasive is abundant and we have Da Vinci robot, so lab and robotic RP-LND is acceptable, but only in a high volume center, and patient selection is crucial. Unacceptable practice will be just lumpectomy alone. That means you just remove the enlarged lymph node. You should not. When you're going in to remove the enlarged lymph node, you should also do a proper RP-LND following the template. I would like to highlight a bit on the post-salvage exception. What it means is that patient has gone through an initial first-line chemotherapy, patient has gone through a salvage or second-line chemotherapy, and then they have still residual mass. This group of patients has high risk of viable disease, and you should not follow the threshold of 1 centimeter. Even in a patient who has less than 1 centimeter residual mass, post-salvage chemotherapy, you should still offer aggressive treatment for the patient, for example, surgery. Yeah, and this group of patients go for bilateral nerve sparing retrocranial limb dissection, which is the standard. This is a diagnostic precision matrix. A summary: seminoma, non-seminoma. Seminoma threshold for action is 3 centimeter. More than 3 centimeter, residual mass, FDG PET scan. And this PET scan, you do it after 6 to 8 weeks. And the reason for us to go for this FDG PET is we want to look for any evidence of persistent viable disease. If it's uptake of persistent viable disease, it is picked up from the PET CT. Non-seminoma germ cell tumor, 1 cm is your threshold. More than 1 cm, go straight for surgery if the tumor markers has normalized. There is no role of FDG PET in non-seminoma. Non-seminoma, no FDG PET. Yeah, remember that. And because we want to remove the teratoma or active disease if there is a residual mass more than 1 centimeter. This is a strategy. So the divergent pathway, residual mass management, it differs between seminoma and non-seminoma. Seminoma, PET. Non-seminoma is mainly surgical driven. The PET scan, PET-CT supports decision making only in seminoma, and positive scans require careful planning. In work for MDT, not all patients with a positive PET-CT for seminoma requires a surgery. You need to discuss in the MDT. Surgical mandate, post-chemotherapy RPIMD remains essential in non-seminoma, and complete resection of teratoma is absolutely critical. MDT is important. We cannot say less about this because it's a high-stake and complex disease. All management should discuss between the oncologist, radiologist, pathologist, as well as the surgical team, urologist. With that, I thank you everyone for your kind attention, and I will see you later during the Protocap meeting.